Thank you, all of them. Thank you, first of all, to organizers of this conference, scientific board, CML community for awarded Ukrainian hematologists such kind of prize. I am very proud and a big honor for me and for my country. I would like to present hematology service for CML patients in Ukraine. It's my disclosure. And what about epidemiology of CML in Ukraine? Population in Ukraine, about 40 million people before situation. Incidence rate is 0.69 per 100,000 population. Male and female equal. Average age of the diagnosis, 48. Number of CML patients who involved in registry, CML registry, at the 1st January 2022 is about 3,500 people. What about diagnostic and treatment in CML patients in Ukraine until 2000? Diagnostic for CML was primitive because based on clinical picture, blood analysis, bone marrow aspiration, sometimes patient did cytogenetic analysis. For treatment using busulfan, hydroxyurea, interferon mono, or in combination with chemotherapy, and in rare case, made a BMT. According such kind of situation and registration TKI, the first is imatinib, in 2028, the support of the Ministry of Health of Ukraine and Novartis company, preparation to provide TKIs to all CML patients with confirmed diagnosis were started. At this moment, all candidate CML patients who underwent this program underwent molecular testing to determine the transcript of BCR-ABL to determine diagnosis CML. It was created program Right to Life. This program uniqueness for the project to present of a clear plan of coordinated actions to cooperation and co-investment between state and manufacturer. Main goal of this program was creating ongoing access to life-saving treatment for CML patients with innovative project to save the life, and implementation of international diagnostic and treatment of CML in Ukraine. Due to before preparation this TKI support program, numerous schools were held for doctors, including annual international conference with participation of opinion leaders from many countries, separately for CML patients with clarification of the program task, the necessary testing, rules for taking Gleevec, monitoring peculiarities. At this time also was created school drop of blood. This organization, including actively participate to international patient events, became member of CML Advocates Network, representing in different governmental institution and structure, and also support the organization, many activities, not only for CML patients and another leukemia, especially during the period of COVID-19 pandemic and military operations in Ukraine. After such kind of activities, CML, the diagnostic and treatment in Ukraine, significantly improved. At the moment of diagnosis, patients made karyotyping or FISH, molecular PCR, qualitative to establish transcript type, and quantitative to monitor response to treatment. Unfortunately, at this moment, mutation analysis in Ukraine not available. And the national target program was provided to improve support for patients with CML, as a pilot project was since 2011, 2014, and then up to now, finding of the program by governmental. What is TKI presented in Ukraine? At this moment, Glivec, then imatinib generic, nilotinib, bosutinib, dasatinib, radotinib in frame of clinical study, asciminib on registration stage, and ponatinib not available. As assessment of the effectiveness TKI therapy is carried out according to ILNET recommendation in clearly established terms. Currently, all CML patients in Ukraine monitored at 3 months of treatment initiation, which allows to determine treatment strategy in the future. We try to analyze overall survivals of CML patients treated by TKI. This is most significant group was treated by imatinib. So 10 years overall survivors is 78%. Ukraine also was involvement in ILNET activity. 29, my organization, National Research Center for Radiation Medicine, became a member of ILNET. The next year, Institute of Blood Pathology and Transfusion Medicine from Lviv joined to this organization. And we participate in ILNET activities. In frame of these activities, Ukraine took part in big project such a European treatment and outcome study for CML, UTOS for CML, the UTOS population-based registry, and project for pregnancy in CML. 2016, I was awarded ILNET Merit Award for integrated in European CML research and implementation, new knowledge in routine practice for Ukrainian hematologists. We made some international research activities. We had collaboration between our organization and the university in Jena, and between NCRM and Children's Cancer Institute from Vienna, Austria. And thanking such kind of activities, publication activities also improved. The next part of presentation continue Dr. Kotlyarchuk, please.
Dear ladies and gentlemen, this is a big surprise and also a great honor and privilege for me to be here and to continue this talk. And this time we would like to move from the general picture of hematology and CML in Ukraine to more specific problems and different issues and how we try to deal with them. I have nothing to disclose. So there are a number of problems and issues that we are facing in Ukraine with CML. Some of them are more or less typical and can be seen also in some other countries, like lack of diagnostic and treatment tools in CML, but there are also others more specific to our country and our time right now, like a migration of population, including patients and medical professionals, and also ruined hospitals and reduction of clinical trial activity, research activity, and some restrictions in traveling possibilities, and therefore no international cooperation possible as it would be normally expected. The striking thing is that even simple things like seeing a doctor and having a blood test could be also a challenge for some of the patients, and mostly those who are living closer to the areas with most active military actions. Moving now to more complex diagnostic procedures like cytogenetics and PCR. I have to say that they are available, but limited to the few centers and sites which are able to perform them. Whereas mutational status evaluation is not possible in the country at the moment. So what are we trying to do with this problem? How are we trying to solve it? First of all, obviously we try to develop and support our local laboratories, and in terms of PCR for BCR-ABL, the first one to start performing this test was laboratory of National Research Center for Radiation Medicine in Kyiv. Later on, our laboratory in Lviv also joined, and now also private laboratories started to join this list and doing PCR for CML also in Kyiv, in Lviv. But there is another point on the map, which is Kryvyi Rih, and this is probably very important, although private, but very important laboratory, which is the most eastern one for CML patients, and this is important for the very big part of them. We also seek international cooperation, and I have to acknowledge International CML Foundation here for supporting our Lviv laboratory within its diagnosis and testing program. And this made it possible for our scientists to get trained in Polish institutions. And later on, they were able to launch BCR-ABL testing for our patients in Lviv. And also now they are doing some other very useful tests for MPNs and other diseases in hematology as a result of this cooperation. Also, next generation sequencing is planned. Even the equipment is already there, but it's too early to talk about this, I think, for now. When the patients need to get their mutational status evaluated, we try to either refer them to other countries for this, or right now we have very, very great support from MLL laboratory from Munich, who analyzed lots of samples of Ukrainian patients, including those with CML who needed evaluation of their mutational status. As regards treatment, as already mentioned, most of the TKIs are available in the country. However, apart from those needed to overcome the resistant mutations like T315I. And this could be a real problem for these patients, given that allogeneic stem cell transplantation and experimental treatment are quite limited at the moment. So what do we do in these cases? We also try to cooperate with colleagues from other countries, and we had this good cooperation with Polish colleagues and with colleagues from the Hammersmith Hospital who treated some of these patients, and this cooperation also brought us to connection with the Max Foundation, who provided several of our patients with the T315I mutation or resistant to all the other TKIs with ponatinib. Another good option for resistant patients would be allogeneic stem cell transplantation. However, this procedure was not available for Ukrainian adult patients until recently. However, this seems to be getting better now, and you can see from the numbers that in 2021 we had almost 200 procedures performed, but only 6 of them were allogeneic for adult patients. But already in the next year, 2022, despite the war started, we had the same number. The total number was the same, but the number of allogeneic procedures increased more than 7-fold. Moreover, this year we had foundation of Ukrainian Association of Bone Marrow Transplantation in Ukraine performed. And this also is possible not only due to the local activities, but thanks to international support. And this time this is a so-called HOOP initiative, or Help Ukrainian Hematology Patients initiative, which comprises many of the organizations and associations dealing with bone marrow transplantation. As regards clinical trials or experimental treatment, obviously with the beginning of the open actions, no new trials, no initiations of new trials were available, and also recruitment of new patients in clinical trials was stopped. But if you take a look at the last graph, you can see that this reduction of clinical trial activity was not that dramatic as it could be expected, just above 16%. And clinical trials is a good option also for CML patients, as we have a history of taking part in them, and patient benefit from participation and for using some new options of treatment as well. As to the other aspects like research activity, obviously it also decreased in recent years. However, scientists from Ukraine keep doing the job, trying to do their job in different directions. For example, in pregnancy and CML, we had 50 cases analyzed overall in Ukraine, and our results were, we were privileged to have them included in publications from European Leukemia Net, and we appreciate the International Cooperative Group for including our data in some of the important publications. Also, TKI toxicity is something that is becoming very important now when we gain more and more experience with using TKIs, and one of our doctors, Natalia Lopina, is working in this direction, and she presented one of her results as a poster presentation at this particular conference. Obviously, we are interested in reaching the treatment-free remission, but this requires to have very reliable and frequent PCR monitoring. Therefore, we don't have many cases, but still we keep collecting them. And we even have one patient who is in TFR for more than 13 years already. And this brings me to our conclusions. Despite definitely some challenges, some obvious challenges like lack of diagnostic and treatment procedures, like need to improve some other procedures, we still have our hematological community doing their best to bring management of CML to the modern level. And international cooperation is something that is crucial for this, to achieve this goal and to develop when the peaceful and normal life is restored. Finally, I would like to thank everyone related to CML in Ukraine. First of all, patients and physicians, and also scientists for doing their job in these times. And I would like to say that we take this prize not as an individual award, but rather as a recognition of the whole hematological community in the country. And I would like to thank them and thank you for your attention, and thank the organizer for this great honor. Thank you.
Thanks very much to all of you. I think that this applause represents very well the support that the entire, not only scientific, but the entire community of Europe is supporting you with the appreciation for what you're doing. Thank you very much. So, if there are specific questions, this is the time for discussion. One of the discussion, indeed, one of the points that was touched was how do you detect the 359 mutation? So previously, Irina said that there are no such a large possibility to detect mutations. Yes. So, and which are your plans to detect this mutation? And once that you have achieved the certainty that there is a mutation which is responsible for, how do you deal with this finding?
To answer the first question, like it was mentioned in the presentation, unfortunately, we look for laboratories in other countries to refer our patients or samples of our patients, and sometimes we have especially these years, we have very good support from these laboratories, so we are able to send sometimes to send the samples or the patients and get the results. If we do obtain the positive result, it depends obviously on the kind of mutation that we receive, and if this is a very resistant mutation like T315I or a combined mutation, then we try to look for good drugs to overcome them. Like ponatinib, we used contacts with the Max Foundation. We look for options to transplant patient, or considering many different options. As to our plans, how to solve this problem, they are simple. We just, well, for now, I think that we have to at least keep diagnosis and treatment at this level, which is already reached. But later we will hopefully evolve, and we have some ideas of cooperation between Ukraine and Poland, trans-border cooperation between our two countries because they are very close. And if we get finances from them, we plan to launch next generation sequencing, and this will also help us very much in diagnosis of these patients.
Thank you. Other questions? I have once more. Was it that the patient is not achieving the milestones as you have, which are recommended by the European Leukemia Net? What do? You are continuing the therapy, or you are just stopping the therapy and moving to hydroxyurea or some other drugs which are less expensive?
Well, since we have 4 TKIs available in the country, so mostly we start with imatinib, and because it's much cheaper, it's generic right now. But in some cases, we also may start from the second generation TKIs from the beginning. But when we don't see the milestones, then we either, if this is imatinib, we can try to increase the dosage or switch to the second generation TKIs. So.
For those who are failing also second generation TKIs, what are you doing?
Sorry?
For those who are failing also
yes. Well, we can try either to switch to other second generation TKIs. We have nilotinib, dasatinib, and bosutinib, so we can try to do it. Obviously, this is an indication for checking for mutations, and this depends on the possibilities that we have. If we do have them, then we try to find whether this patient has a mutation or not. And we also start discussing with the patient options for allogeneic stem cell transplantation, which are limited at the moment, but there are centers that evolve, and this increase in only 1 year and troublesome year shows us that it's possible that in next years this problem will be solved as well.
Okay, no, I'm asking this because there was a recent publication that you probably know has been published just 1 week ago or 10 days ago on leukemia by the German group, showing that indeed these patients, even if they are not matching the European Leukemia Net milestones, indeed they can have an advantage of continuing the TKI therapy. Of course, in your case, you are moving from imatinib to nilotinib and dasatinib. Then, in case of failure, do you continue on the same TKI, or you go back to imatinib just to have, or you go to hydroxyurea? This was the reason why.
Yeah, that depends on each individual case. There are some patients who took imatinib, and then I have to say that sometimes there is a drug supply, and then it's over, and patient is switched to some other medications even due to this reason. So when we know that the patient didn't really fail, didn't have a failure on imatinib or some other drug, we might go back to this medication. Also, we do use hydroxyurea in some cases. We also look for clinical trials, and for some patients, this could be the option.
Thank you very much. Are there other questions? If not, thank you. I think the team, you are the last.
Thank you.